So the decision about how to treat a premenopausal woman with adjuvant endocrine therapy has a few different elements, and one is the patient's risk of recurrence. That's very, very important. So how big is the cancer? Is it involving lymph nodes in the axilla? And so somebody with a higher risk of recurrence will get a larger benefit from, for example, ovarian function suppressing strategies. We know from the soft and text data that women who were either under 35 or who received chemotherapy, which for me is basically a surrogate for higher risk disease, those patients got a benefit from ovarian function suppressing strategies, so ovarian function suppression with tamoxifen or with aromatase inhibitor compared to tamoxifen alone. So that's the major factor that goes into my recommendation, is how concerned am I about risk of recurrence. For patients who have a stage 1 cancer who are not under 35, I tend to recommend tamoxifen monotherapy. But for a patient who is either under 35 or who has a node-positive cancer, I usually suggest an ovarian function suppressing strategy. Now, the other question is that sort of answers the question of the first 5 years of treatment, but then what to do after that, whether to extend endocrine therapy. And in that decision, I often consider both the risk of recurrence and also the patient's preferences and values and how she's feeling already on the first 5 years of treatment. And certainly side effects are also a major concern with regard to that first decision about tamoxifen alone versus ovarian function suppression with tamoxifen or ovarian function suppression with aromatase inhibitor. No matter what you choose up front, if somebody has a lot of trouble with it from a quality of life standpoint, it's not going to work out. And so I end up changing people from one to another depending on side effects and patient preferences. At the main side effects that we see with ovarian function suppressing strategies include vaginal dryness, aches and pains, and some patients experience significant depression. So whatever decision I make up front doesn't necessarily end up being the final decision for what somebody's able to be on for 5 or 10 years. And certainly those discussions are ongoing, and the patient's preferences here are a major, major factor.